with Robbie. I will do it again. Hello, everyone. Welcome to another VMR. Today, I'll be discussing with Robbie for the second time, and I'm really excited. I think if anyone has a case and want to present, please let us know. And Robbie, how are you
I'm
doing?
really good. I get to hang out with you today and this crowd. I'm so excited. And it's the first time that I've been here that the majority of the people have their video on, which is subtle but important pressure off for those of you who aren't turning your video on. Come on, do it, do it, do it. But I'm really excited. Yeah, it is a very clinical heavy day for me. I was at morning report, UCSF morning report, and then I had this, and then I'm going to see patients all day long. And so I'm ready. I'm ready to dive in with you and get started today. And look, Juliana turned her video on. Hello. Can you tell us about yourself? I don't think we met before.
Hi. I've been here, I think like one time, maybe 3 months ago.
Wow.
And today was my email entrance, and I was like, oh, I'm gonna join today.
Yes.
My name is Juliana. I am from Brazil, and I plan to do I'm already a physician here. I graduated in June this year, and I'm planning to do my residency in the US, currently studying for the steps, and really happy to join you here today.
Amazing, Juliana. It's a real pleasure to meet you. Your fellow Brazilian is co-discussing today. I will be passionately rooting for your country tomorrow morning my time. Whenever you're inclined to join us in the future, if you have a case and you can put it on your CV for application, it goes a long way. So think about that, and would love to discuss a case with you if you're able to next time.
Yeah, I'd love that too. I'll prepare one and
beautiful.
Bring one of your VMRs.
Amazing. Anyone have a case for Deborah today?
An easy one. Robbie, how much will be the game tomorrow?
Oh, I think it'll be 3-1 Brazil. That's my best guess. Yeah. What do you think?
We're gonna win.
Yeah.
So.
Wait, you made me guess the score, but you're not gonna guess the score. What's the score?
Okay, maybe let's say 2-1.
2. Well, you're like a little cautious, huh? Okay.
Yeah.
Oh, amazing. All right. Well, Ravi is kind enough to have a backup case ready for us, and since we're only 30 minutes today, we'll jump in and lean on Deborah to kickstart off this discussion. Thank you, Ravi.
Oh, you're welcome, man. Actually, the case I had from Morning Report, so I just want to give a shout out to Faisal, one of our residents for this case. So the chief complaint, 86-year-old female who presents from home and is having fatigue for about 1 week. The fatigue is associated with palpitations, exertional dyspnea, and she's also endorsing some left-sided abdominal pain. And I'll stop there.
Okay, so we have a lot here. I think I would separate and give my thoughts on each one. Every time I heard the word fatigue, I remember one podcast that I listened from Raza that he said that anything under the sun can cause fatigue. So every time that crossed my mind, but we have like the most common causes like diabetes, an infection, anemia, a heart failure, and I think hypothyroidism, a chronic renal failure. So yeah, fatigue is really can go with everything. And thinking about the exertional dyspnea, I was gonna ask for first the time, how long time she's feeling like that, and how like this exertional is, like if the patient can do something in the house, can washing the dishes, if the patient can walk to the supermarket, to measure how the category of this dyspnea. And we always think about like the main causes, that pulmonary and heart and other causes, and pulmonary, some COPD, asthma. We think about the vessels too, like a pulmonary hypertension, vasculitis, the heart failure, and other causes like acidosis, anemia. And it's a lot of information for now. And the left abdominal pain, I would try to know when started. I think that's where I would think, and then I would think like the area. I would do a physical exam to see if hurts with the palpation, if it's tender, not tender, distended, and thinking about exactly where in the left, because left we divide in 3 parts. So I think about what organ could be involved. I think we need more information, but I think that's where I would start.
Deborah, absolutely amazing. I have nothing to add, and we'll just take the time to summarize. But first, I want to shout out Joy, who just stepped away from her computer, but she had an incredible discussion yesterday in Stefan Zavin's VMR. It was really great to see you here, Joy. And I will say that your thoughts are very, very comprehensive. And I think that early on you should be comprehensive, but I will just try to paint what is the most likely scenario, making a lot of guesses. So dyspnea, heart, lung, other. Palpitations suggests heart, but not confirms. Heart plus abdomen usually means either inferior myocardial infarction or congestion, passive congestion into the abdomen, or most concerning would be a cardioembolic embolism. So that line of thinking that we drew is many assumptions, but that is probably the most likely way you'd connect the palpitations with the left-sided abdominal pain. But you have to do both the way Deborah said it and the way I said it at the same time, because the way Deborah is saying it you'll never miss. You'll be very comprehensive. But if you're in an emergency room, you have to be comprehensive, but also fast. So the thinking fast is what's called S1 thinking in clinical reasoning. And in S2 thinking, you saw that demonstration. There is no S1 versus S2. It's S1 and S2, knowing what you need to focus on quickly, but also knowing the whole picture. So I will try to do that throughout this to be the S1 equivalent for Deborah's thoughtful analysis. All right, Ravi, tell us more.
A little bit about a past medical history. There's a history of anemia, MGUS, MGUS, hypertension, pulmonary hypertension, and sleep apnea. Regarding social history, nothing there. Family history, hypertension, and also myocardial infarction on the father's side. No history of surgery. And then only 2 medications, amlodipine and losartan for the high blood pressure. I'm going to jump to the exam as well, once you're ready. Okay, temperature 36.3, heart rate 96, respiratory rate 20, blood pressure 156/77. Generally appearing to be well, and significant findings: eyes, conjunctiva pale. Rest of exam is normal, and you also notice urine that's been collected to be sent off, and it's dark. And I'll stop there.
What do you think, Deborah?
Yeah, so the patient has a past medical history of anemia, so I think maybe we could associate that with the fatigue. I don't know if this anemia is from a vitamin that is missing, if the patient is eating, how the patient eats, if it's a chronic disease. Maybe that could be associated about the fatigue. So I would like to investigate it more, that the patient has hypertension and the blood pressure is high and the patient takes medication. So I don't know if that can be, if the patient is really taking care of the hypertension, if he's well controlling that. I always think about that. And I was thinking about the dark O-ring, and I don't know, I don't know if dark could be like blonde, what could be like involving dark, but maybe hemolysis could be a cause. And I think that's where my thought.
I think you nailed it. I think that should be your leading thought is, could you be worrying about hemolysis? My only piece of advice in this case is whenever you see MGUS, monoclonal gammopathy of uncertain significance, is to write under it, tiny font under it, of uncertain significance right now. And it may evolve into something more obvious. So thank you, Maddie, appreciate that very much. So the question is this MGUS now become of significance? And I think the case for hemolysis here is pretty strong, as evidenced by the dark urine and the pale conjunctiva suggesting anemia. So the question is, what kind of hemolysis is this? And the first step is to confirm hemolysis and then get two things: a Coombs test to look to see if it's antibody mediated, and to look at the peripheral smear. The most common scenario is that this patient of MGUS presenting to hemolysis is this patient has a cold immune hemolytic anemia. Those patients tend to have a high rate of previously diagnosed MGUS, and the age of the patient also fits with that. It usually is older adults. So the smear will be very important here to look for both spherocytes, which are associated with immune hemolysis, but also to look for rouleau formation, which would suggest cold-induced disease. At this time, how can you make the case stronger even before getting any of the data, because it'll come back 1 hour later, is to ask the patient about any cold-induced symptoms, like cold-induced acrocyanosis or painful and ischemic digits, and whether she knows to avoid the cold because of feeling poorly, and whether she's been exposed to cold as a trigger for this possible event. All right, Ravi, why don't you tell us more?
Sure. Absolutely wonderful discussion here. It's interesting. There was a morning report yesterday, and I actually went through this same sort of thought process. So you're right on the money. So labs, white count 8.2. Hemoglobin is 5.3. MCV 129. Platelets 178. Chemistry, the abnormal values: potassium 5.1, AST 273, and total bilirubin 5.7, of which direct was 0.6, LDH 847, haptoglobin less than 20, reticulocyte count or percent greater than 23, and the peripheral smear showing macrocytes and microspherocytes occasionally, and the You want me to give the Coombs test, Ravi?
Whatever you feel like.
Okay. Oh, maybe we'll pause there, see what you think, if there's anything that you can squeeze out of this.
Yeah, I think the hemoglobin, the patient is anemic and is a microcytic. So probably I think a megaloblastic. I think it's just like that I should say. Yeah, and check the folic and vitamin B12. And the LDH indicated it's high, so that indicated hemolysis. And let me think what else I could see here. The reticulocyte, if I'm not saying wrong, I think it's higher too. And maybe we need, yeah, the cone test. And I think, yeah, without LDH, I really think about hemolysis. And what do you think, Robbie?
Yeah, I mean, it's incredible how much progress you're making with your thinking. First, you were very broad and brought up anemia from the beginning. And then you saw the exam and you brought up hemolysis. And then after hemolysis, you're confirming hemolysis by high reticulocyte count, high LDH, and low haptoglobin. So now, if you just Google approach to hemolysis or go CP solvers, you'll find the answer. So your growth, you haven't found your growth point, Deborah. Everything has been so easy for you. So now the hard question for you is, and we should talk about it, is what is the DDX for hemolysis plus high MCV? And you said one already. You said megaloblastic anemia. So what can happen when you have folate deficiency or usually B12 deficiency, but sometimes also MDS, is you make a big red blood cell in the bone marrow and you can have intramedullary hemolysis or hemolysis within the bone marrow. So that can cause a nutritional deficiency to cause a hemolysis. So megaloblastic is one cause of high MCV and hemolysis. With some time, can you think of any other causes that we should think about in general?
I'm thinking, I don't know if maybe microangiopathic hemolytic anemia.
Yes.
I don't know.
No, correct. In fact, any cause of anemia severe enough to cause prominent reticulocytes, and MAHA as an example. So the red blood cells can be big because of megaloblastic changes, or the red blood cells can be big because the reticulocytes are so common here, above 23%. There are two other causes. The other cause is cirrhosis. So patients with cirrhosis have a high MCV for multiple mechanisms, and they can get hemolytic anemia through multiple mechanisms too. So you'll see in patients with liver disease can do it too. And then finally, you can get it from rouleau formation. So the MCV is not high, but the automated smear sees it as high. And so if you're thinking, what's my DDX for hemolysis plus high MCV? The truth is any cause of hemolysis, if it's causing the reticulocyte count to be high, then it will cause high MCV. And then the other ones are megaloblastic, rouleau formation, and cirrhosis. But here, we don't just have a high MCV. We have a ridiculously high MCV. And there's only two causes of hemolysis with a ridiculously high MCV, defined as over 110, 115. And those are megaloblastic, like you said. We should definitely send a B12 here. And the rouleau formation. So here, what makes megaloblastic a little bit less likely is that you did not see the hyper-segmented neutrophils on the peripheral smear. So this case, if you filter it by hemolysis plus high MCV equals cirrhosis, reticulocytes, ineffective megaloblastic anemia, and then finally rouleau. Cirrhosis not happening. Reticulocytes possible, but the MCV is too high. Megaloblastic possible, but you didn't see any hypersegmented neutrophils on the peripheral smear. And then rouleau. Rouleau, and you revisit the history, you're like, wait, hold on. She's 86, the perfect age for colon-induced disease. She has MGUS, the perfect risk factor for colon-induced disease. And now she's presenting with intravascular hemolysis. This case is very, very suggestive of cold-induced hemolytic anemia. Practically, what does this mean? This means that you have to make sure that this patient is really, really warm. It's very counterintuitive. Many times us doctors, especially people who are internal medicine, ER, or anything, are rushing to give this patient a medication. But you should rush to give this patient a blanket. Trust me, there's nothing else that's more important than keeping her really, really, really warm right now. Any other thoughts, Deborah, before we hear from Ravi?
No, I have to tell you, I never heard about this Rolo,
Yes,
and maybe if you can explain, maybe
course.
it's the language, maybe I
Oh
don't know.
yeah, I think you've probably heard of it, and the term rouleau sounds so fancy, but let me explain. In the this antibody, the cold antibody is an antibody that causes red blood cells to attach to each other, and the attachment of a large number of red blood cells makes it look like a big clump of red blood cells. That big clump makes the MCV machine look really, really large. And someone, I think it's Mukund, has kindly shown, you see all those big line of fully attached red blood cells? What's attaching them, thank you, is the cold antibody, and the attachment is called rouleau. And the rouleau, this one big line, the machine reads it as one big red blood cell, making the MCV very high. Does that make sense? Good, awesome. Hopefully we're not wrong and Ravi just tells us something completely different, but either way we'll learn. Tell us more, please. Ravi.
There's a wealth of learning here. So the Coombs test returns back, and I was right in the right along the same path there. I was like, yeah, it has to be cold hemolytic anemia, but the Coombs test came back positive for IgG, and so in fact was a warm hemolytic anemia. So I traditionally sort of use this mnemonic: cold ice cream is MMM, like so that's like mononucleosis, mycoplasma, multiple myeloma, malignancy like lymphoma. But I did a quick search, and actually you can have associated with multiple myeloma warm hemolytic anemia. So this also was something new for me. So I thought it would be a great case to discuss. But with this patient, the treatment was giving first stabilizing the low hemoglobin, gave transfusions, and also then giving steroids 1 milligram per kilogram. And the patient did not respond, and then escalated to rituximab therapy. And then there was improved markers of hemolysis, and the patient is now under the care of hematology. So it's a case of warm hemolytic anemia associated with MGUS.
Amazing case. Deborah, what do you think?
Oh, I am not a big fan of hematologic disease, but this was good to give some thoughts and know learning more. And I just put in the chat like a schema that has on the website that really helped me to think about the warm and the cold one. So yeah, it was a great discussion. So thank you for this opportunity, and thank you for the case, Ravi.
Deborah, if you just revisit your reasoning, you said anemia, and then you said hemolysis, and then you said, oh, it's definitely hemolysis. You were right there. And I think there's all sorts of learning for me and you. And for me, the learning is, I was still surprised that somebody this age is having a warm immune hemolysis. Is a great lesson. It makes me want to read more about how the MCV is so high. Maybe it's the reticular. I'm not sure what it is. And I think one nuance to introduce there is that Ravi's mnemonic is really helpful. IgG is warm, IgM is cold. The truth is that that correlation is almost perfect, but it's not 100%. Though you can actually measure in the lab, we'll measure what's called the thermal amplitude, or we'll measure the temperature at which the antibody is most active. So to make things complicated, you can have a cold induced, you can have an IgG that's cold and an IgM that's warm. It's very rare. And if you really want to know, you can just measure the maximal temperature at which the antibody is active. So very interesting case. The thing that actually seals the deal really for warm, even if you don't know the thermal amplitude, is that cold-induced disease doesn't usually respond well to immunotherapy. And it's very tricky and hard to manage, and patients often have chronic low-grade hemolysis and they have to stay warm. So the fact that this patient improved with immunosuppression is another reason to support the warm. Ravi, I'm curious what, before we hear from Mukund and Himrak in this case, I'm curious what learning you took and emphasized in this case.
I think just the point that you brought up, if this patient had any of these manifestations during a cold event, so if you go back to the history, this has happened in a normal body temperature, not out in the cold or stuck in the cold, and then the symptoms were brought on by that. So if that was in the history, I think we would have then deviated towards a cold hemolytic anemia. But then you also always have to keep your mind open that you can have occurrences. Typically this could be cold associated, but the alternative may also be considered in a patient with this presentation. So I definitely learned from this case, and I thought it'd be a fun, quick journey through the river of blood, hemolysis, hemolytic anemias. So a lot of great teaching here for everybody involved today.
Thank you, Ravi. Thank you. Deborah, how did you feel discussing now? How does it feel?
Good. I feel that we are friends here, so I don't get so scared anymore. Took me a while to speak, so now I can talk more.
Yeah, now you can talk and suspect hemolysis right away, even before the labs come back. It's kind of crazy, honestly. All righty, Mukund, take us home, please.
Sure. So we're back to one of my favorite disciplines, heme. We started with the chief complaint of fatigue in an older patient, for which we had an excellent discussion of assessing functional capacity and ADLs. We talked about, with the initial presentation of heart and abdominal symptoms, thinking about 3 morbid diagnoses: inferior MI, passive congestion, and cannot miss of cardioembolic stroke. But then we entered the realm of hemolysis. We spent the rest of the time talking about the differential for a significant macrocytic anemia. There were some clues in the physical exam: anemia, pale conjunctiva, and dark urine, which all suggested hemolysis. And we talked about how with this patient who has a monoclonal gammopathy of undetermined significance, as of now, it's very likely that given the age of the patient and given the MGUS, a cold hemolytic anemia is at play, which would present as spherocytes and rouleau on smear. And just as a recap, rouleau are something that are seen on a smear when red blood cells agglutinate and form these kinds of chains, and I've included an image here for reference. On our history, people want to assess for cold-induced acrocyanosis and cold exposures. We moved on to having some lab values to work with, and we saw a significant macrocytic anemia, almost to the 130s, with a low haptoglobin, a high LDH, and a high reticulocyte count, all suggesting hemolysis. So we went into a diagnosis for macrocytic anemia, of which there are several, megaloblastic causes being one, reticulocytosis being another, cirrhosis and liver disease being a third, and rouleau being the fourth. And we talked about only rouleau and megaloblastic anemia as causing macrocytic anemias to this extent. In the end, of course, we were surprised by this being a warm hemolytic anemia rather than a cold one, although we had a very interesting discussion of thermal amplitude testing for autoimmune hemolytic anemias as a way to confirm cold versus warm. That's it.
Amazing. Thank you so much, Mukund. It's so nice to have you back, and I'm glad it's in a world that you know and enjoy. All right, y'all. For those of you watching on YouTube and everybody here, our beloved Kirtan, who is now an intern in Chicago, has saved up a very special case for tomorrow's RLR VMR. He texted me all excited about it, which I'm both delighted that he's back, but also terrified to discuss a case that he not only has saved up. Can you imagine? So if you can make it tomorrow, I would really, really try to prioritize it. All righty. Thank you again, Deborah. Thank you, Ravi. Thank you, Mukund. Thank you, Maddie and Yasmin. We'll see you all later.